Hi, welcome back to my YouTube channel. For those of you seeing me for the first time, myself Dr. Roja with specialty in psychiatric nursing. For your information, I have been doing different videos on different types of mental disorders in my previous videos. If you go back and have a look, you will be able to go through them. And for those who are seeing me for the first time, please do subscribe and share my channel to others, as it would be helpful for others too. For today's topic, I would like to discuss about mental status examination. As you all know, mental status examination is a very important aspect of psychiatric assessment, and we as a nurses do mental status examination for patients. And when we do, and for those who have done, you already know it takes a lot of time and patience on our side. Mental status examination is not done separately as such, but in parallel with psychiatric history taking, we do mental status examination. So this is very important subject and aspect in regard to patient care, psychiatric patients care. So we are going to look in detail regarding mental status examination and different aspects it covers, and what data or information we need to gather while doing mental status examination for the patient. So coming to the components of mental status examination, when we are doing, we gather information related to general appearance, behavior of an individual. Then we gather information on speech, we assess mood and affect, thought of the patient, then perception, cognitive functions, etc. So just we will go in each aspect very detailed formatted. First we'll look at the general appearance and behavior. So appearance of an individual, looking at one's age, we can say that whether they are looking older or younger to their age, or underweight, overweight, physical deformity. Looking for facial expression. When we look at the face, we can understand whether they are anxious, pleasant, fearful, or blunted. So when we use this word blunted, it means that face which does not express anything. We don't see happiness or anger or anxiousness or whatever it is. When it is blank, flattened, we call it as blunted facial expression. Next aspect is level of grooming, how they are looking, normal dressed or shabbily, overdressed or dressed properly. When we say overdressed, sometimes in maniac patients we see like they are flamboyant or dressing contrast colors like red and green colors. So such type we call it overly dressed, idiosyncratically dressed, with not at all, no combination at all, attaching different other objects on their bodies and looking very funny at times. So meaninglessly dressed. That is called as idiosyncratically. This is said like level of grooming, how whether they are looking neat or clean, including their combing their hair, whether it is tied up well or not. That is called as level of grooming. Next, coming to level of cleanliness, adequate, inadequate, overtly clean. Mode of entry. Mode of entry, when we call them for gathering information, whether they came willingly or persuaded. When we use this word persuaded, it means that we just go behind the person, just request them to come and talk to us, then we want to gather information. So being behind the person again and again, then at last they just cooperate with us. That is called as persuaded. Next, brought using physical force. So brought using physical force means patient is not willing, that we can understand. So when we try to bring the person by using physical force, that is a tough task actually, because we quite don't get the information what we want. Am I right? So next, another aspect what we usually assess is behavior of an individual, whether it is normal behavior, over friendly. When we say over friendly, whom we can see this over friendliness? Maniac patients. They are very excited. So we see that over friendly, just cooperating with us too much, giving information more than what we ask for. That is like over friendliness, just laughing and giving all the information. And next one is preoccupied, whether they are preoccupied. Who we can say preoccupied? Those who are having depression, maybe preoccupied with their thoughts. They don't give us much information whatever we ask, because they are morely engrossed, preoccupied. Sometimes we see them in autism, mentally retarded cases as well. They don't focus on at present what we are asking, but they are mostly preoccupied with some thought or the other. That is just noticed. Next one, aggressiveness also. Those who are very anxious or paranoid, schizophrenia patients, where they have delusions of persecutions, that others are hurting them, trying to do some harm. They become sometimes aggressive. Those with psychotic features, they become aggressive as well. And maniac also, when the psychomotor activity is too much, they also become very aggressive. Next is level of cooperation. So when we ask something, how cooperative they are. If it is normal, we write it as a normal. More than so, more than so, too much cooperativeness. That means, as I said, like in maniac patients, they are more cooperative. Less than so, some of them who are very anxious, they do not cooperate. They say, no, 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 I don't want to talk, I'll talk later. That's like less than so. Then coming to the next aspect, eye to eye contact. Whether we are able to maintain eye contact with them, or when we are looking into their eyes, whether they are looking somewhere preoccupied sideways, or this they are just looking down, they are not able to maintain eye contact. Maybe they might be able to see into our eyes, but that sustenance is not there. So we can just put whether it is maintained, difficult to maintain, or not maintained. Next, coming to psychomotor activity. When we say psychomotor activity, it's like sometimes we see overactiveness or restlessness, more excitement in maniac patients. So psychomotor activity is usually increased in maniac patients, and in depression patients it is decreased. So we can assess according to their level of activity. We can write whether they're normal or increased or decreased. Next, coming to rapport. How is the rapport? How they are talking with us? Whether it is spontaneous or difficult, not established, only one sided. We are trying to establish rapport with them or initiate conversation with them. And if they are also initiating, responding to us, then we call it a spontaneous rapport. But they don't respond, only we try to initiate. It is difficult, and sometimes they don't respond at all. That we say it is not established. Next, another one is gesturing. So gesturing, we say whether normal, exaggerated, or odd. Posturing, how they are sitting, basing upon their position, we can say it's like normal posture or catatonic posture. So catatonic posture, we see like in catatonic schizophrenia, where a patient stands in a particular awkward position or a posture for a prolonged period, we call it as catatonia. So where that word waxy flexibility comes, like no wax, wax, how we can wax, we can, when it is heated up, and we can bend it in or mold it in a way whichever we like. In the same way, patients who are having catatonic schizophrenia, they maintain an awkward posture for a prolonged time. So In posturing, we can observe whether they are in normal posture or catatonic posture, stooped posture, that means bent forward. In psychotic conditions, we see sometimes like stooped postures. People usually just bend forward and just look like that. Then stiff, where we cannot move. Guarded. Guarded, this word can be used like no persons who are suffering with persecutory delusions or anxiety, where they're very much guarded when they feel that they're unsafe and they need some security, or when they feel that there is a threat coming from all the ways. So these are all delusions what they have. So when they have these delusions of persecution, they try to guard themselves, safeguard themselves. That is like guarded look, always alert, looking this side and that side to see whether they are in safe place or not. That is called as guarded. Next, we have other moments like normal. If they are under other moments, we can assess whether they are normal. Other than that, stereotype. When we say stereotype, it is like repeated movements, like mannerisms, like lifting their head. Sometimes we call it like, it's not related to any neurological condition as such, but everybody have some repeated movements what they particularly do, like mannerisms. So those types we have to observe in the patient. Next, we have tremors. We should observe for tremors. When we say tremors, it's like shivering of fingers and hands. Next one is EPS. EPS is extrapyramidal syndromes. So extrapyramidal syndromes, when we say those who patients who are on antipsychotics, like they develop side effects called as extrapyramidal symptoms. So under extrapyramidal symptoms, we have symptoms like Parkinson's, where the person will be having wavery gait. Then there are different symptoms like akathisia, dystonia, tardive dyskinesia. Then we have neuroleptic malignant syndrome, that is a very big complication part of it. So EPS means these are certain symptoms which we see in that. Ataxia will be seen, dystonia, as said, akathisia, and so we will, if you want to know regarding the CPS in detail, you can go back to my schizophrenia video, which is done on disease condition schizophrenia, and you can get in detail regarding EPS. Then you have to check for abnormal involuntary movements as well. Coming to the next aspect, catatonic phenomena. So as said, catatonic phenomena, I have already said, like placing themselves in an awkward position or odd position for a prolonged period. So under catatonic phenomena, those who are suffering with catatonic schizophrenia will be presenting this catatonic phenomena. Under that, we have automatic obedience. So automatic obedience, whenever we say something, whatever they are doing, they just like listen to that and follow that order. That is like automatic obedience. We play some statue game. People keep running, moving around. The moment we hear that word statue, we try to just stay in the position, whatever position we are on. So that is like automatic obedience. Next, negativism. So doing whatever opposite of whatever we say is called as negativism. Then excessive cooperation. Then waxy flexibility. Already I have explained. Then we have to observe for echolalia and echopraxia. When we say echolalia, repetition of words is called as echolalia. Whatever we say, what's your name? What's your name? So repetition of words is called as echolalia. Echopraxia, coming to repetition of actions, we call it as echopraxia. Whatever we do, if we just do like this, they'll also just do like this. If we try to give shake hand, they just give shake hand. Or if you try to do something like this, they also do like this. So repetition of actions is called as echopraxia. We need to observe all these things when we are doing mental status examination initially. Then apart from that, we have conversion and dissociative signs. Under conversion disorders, we have hysterical fits and the which we call it as pseudo seizures, then dissociative signs also. You can just go back to my previous videos on conversion disorder and dissociative disorders to just look at different conditions we have dealt. Then coming to compulsive acts and rituals and habits, these are mainly discussed in OCD. Obsessive compulsive disorders we have discussed regarding that. So what are obsessions and what are compulsions? Repeated unwanted thoughts are called as obsessions, repeated unwanted actions are called compulsive acts. Then we need to also observe for any hallucinatory behaviors, hallucinations. So in schizophrenia we have gone in detail related to hallucinations as well. When we say hallucinations, it is all related to different types of senses: visual hallucinations, olfactory, gustatory, auditory hallucinations, hearing voices, seeing people. In absence of any external stimuli, we call it as hallucinations. Now this is all about general appearance and behavior of an individual. So these things, when we are taking psychiatric history taking itself, we can observe the person. We need not separately make person sit and just do strictly mental status examination, but while doing, as said, in parallel to history taking, we can observe a person's behavior, how they're looking, if we ask how they're responding, what they're doing, all these things, whether they're interested in talking or not. Next, coming to the other component of mental status examination, that is speech aspects. So in speech, we are going to assess initiation, reaction time, rate, productivity, volume, tone, relevance, coherent, etc. For this assessing speech, we need to have a sample of speech, and we have to write a sample of speech in verbatim as well. We can ask questions like, what is your name, what did you eat, what have you done yesterday evening, and all those things. When we talk to them, how they are responding, basing upon that, we can assess all the components which are here. Initiation, whether it is spontaneous, speaks when spoken to. When only if a person is responding only when we talk to them, then maybe we can write speaks only when spoken to. Or minimal, when if we ask 2-3 questions, they respond to us in a short frame or a word, we call it as minimal. Mute, if they don't talk at all, we can write this term mute. Now especially catatonic schizophrenia, most of the patients, they follow this mutism, they don't respond. Or if a patient is in severe depression, here also they don't initiate, they talk very minimal, or sometimes they remain mute. Next one is reaction time. Normal, delayed, shortened, or difficult to assess. How they react while their conversation goes on, while during the conversation, how they are reacting. Whether they are reacting immediately or delayed. Once we ask a question, they take a prolonged time, then react. Delayed reaction. So next, coming to rate. Normal, slow, rapid. If we see maniac patients, they are rapid. Flow of words will be many within a short span of time. If we just take a look at depression patients, they are very slow, talking minimal words and taking gap between each word. That we can write as the rate of speech is slow. Then productivity, monosyllabic. When we say monosyllabic, one word. Yes, no, true, did, ate. So monosyllabic. Then elaborated replies. Who gives elaborated replies? Those who talk Those who are very expressive, they will give elaborated replies, especially sometimes maniac patients in some cases. Then pressure also. Pressured speech mostly we see when they are very aggressive, anxious or maniac. Next, coming to volume. So you all know volume. When we say volume, when you're listening to some song, you try to increase the volume or decrease the volume. The same way when patient talks, what's the volume? Normal or increased or decreased? Very low sometimes. In depression patients, volume is very low. When they are very sad, it is very low. Next, coming to the tone, normal variation, high pitch or low pitch, monotonous. Relevance, whatever they talk, if whether it is relevant or not. If I ask what is your name, you say, like, we respond like, my name is Roja. You might respond, my name is Anita, or my name is Kamala, like that. But if you respond something else, it's not relevant, isn't it? If I ask what is your name, my age is 50, it's not relevant. So sometimes off target. Off target, when we try to ask something, they respond something which is not related to what you have asked for. That is called as off target or irrelevant, no connection at all. Next, coming to coherent, fully coherent or loosening of association. So when there is a connectivity between one sentence to another sentence, we call it as coherent. My name is Rocha, I am a nurse or a mental health nurse working in so and so hospital. There is some connection is there. It makes a sense or a meaning. So that we say fully coherent. But there is like loosening of association. My name is Rocha, I ate mango. Is there any association? Okay, 10 days back I played throw ball. Rama is coming, Sita is going. If I just make such type of sentences, I don't think there is any meaning in that, isn't? Loosening of associations. Then others, under others we have neologism. Neologism is nothing but coining of new words, we call it as neologism. Coining of new words, words which we don't know meaning, we don't find meaning, like some movies we just observe this killy language or newly coined words which we don't find meaning. That is neologism. Next one is perseveration. So repeating the same word again and again, we call it as perseveration. So this all can be assessed under speech. For that, when we are taking psychiatric history taking, we can assess for that, or when we are initiating and when we develop rapport with the patient during their conversation, we can assess by asking some questions. Next aspect is mood and affect. Now, what is meant by mood and what is meant by affect? Many of you have these doubts. Affect is a temporary one, what we see in a person, a feeling. When it is sustained for a prolonged time, we call it as mood. For example, if we take an ocean or a sea, whatever it is, waves which just comes, sometimes big waves comes, sometimes small waves comes, they touch the floor and they just go. Waves we consider as an effect because waves keep changing in their height or force, etc. So if waves are considered as an effect, ocean which remains stable is considered as mood. We can take seasons also. We have different seasons like rainy season, winter season and summer, etc. But the weather keeps changing, isn't it? So we can take weather as an effect and season as a mood. I hope you got it. Something which is sustained for in a person for a prolonged time, what you see in a person for most of the time, we call it as mood. And the effect is a temporary one which just keeps changing. So mood can be assessed subjectively as well as objectively, where we can ask a question: how is your mood today? How are you today? How are you feeling today? So they try to respond, I'm fine, I'm very happy. That is subjective answer. But objectively, you have to see in their face how they really are. So if they say like I'm so happy and face doesn't show look bright or happy, we is it appropriate? No, it is inappropriate. Suppose for example, if you take a schizophrenic patient who responds like when you ask how are you feeling today, if they say I'm so happy and their face is just blunt like this, flattened without any emotion, it is very inappropriate, isn't it? So, predominant mood state also irritable, labile. When we use this word labile, that means shifting of affects or feelings. For short period they'll be very happy, but the next moment they become very anxious, they shout, they show anxiousness, they become aggressive, all these things. So shifting of rapid shifts in moods, we call it as labile. Blunted, just now what I have showed is blunt, there is no expressionless face, that is called as blunted. Next, anxiousness, we can observe if they are anxious, fearful, panic, aggressive, cheerful, depressed, etc. So according to what we assess from the patient, we can say mood is appropriate or inappropriate. Next, coming to thought. Under thought, we assess for stream, form and content. Now what is stream? As we talk with the person, now I am talking, there are you can notice there are flow of words and sentences coming. So flow of thought, whether it is normal or racy thoughts. Racy thoughts, when a person is very aggressive, they talk very fast and words come very pressurized. Words are very pressurized. When they're in patients, when they're in manic state, usually you see them like very, you observe in them racy thoughts and pressurized speech. And if they are depressed, you see retarded or poverty of thought. Poverty of thought. They don't, when we ask them, what are you thinking of anything? No, I don't have anything to think. No thought comes into their mind. Then we can see for thought blocks. So usually when I best example for thought block I can tell you is that during your practical examinations you face this one. When an examiner just asks some question during viva, you know the answer but you won't be able to bring it out. So you say, I know the answer, but it is stuck. You're stuck somewhere. You try to repeat it. You say a part of it and just stop. Thought block. And next one is uncleared or muddled, untidy. So not very clear about thoughts. We say it as muddled. Then flight of ideas, jumping from one topic to another topic or one thought to another thought. We say flight of ideas. So, like starting with something and moving on to something. Clang association, meaningless sentences or meaningless connections are called as clang associations. Next, we have mutism, when they don't say anything at all. When they don't talk anything, we call it as what? Mutism. Next, coming to formal thought disorder or thought form of it. Normal, not understandable. Then we have circumstantiality. When we say not understandable, it is like we don't understand what they're talking. But when we say circumstantiality, when we ask a person like, how can I explain this? adding extra details before coming to the actual answer is called as circumstantiality. For example, if I tell, where is your nose? You can point your finger here, isn't it? But instead of that, pointing, you go all around and you come here and you point, this is my nose. That is called as circumstantiality. Maybe this is a better example, I feel. Otherwise, you can just ask a friend, suppose for example, this does happen sometimes. So when did you start from your home? Then maybe the other person responds, me, actually I got up around 3 a.m. early morning because I was very anxious whether I'll reach on time. Then I started arranging my things. Then I went for bath, brushed my teeth. I made some breakfast for myself. Then I packed all my things by 5 o'clock and I reached bus stop by 6 o'clock. So I started around 6 o'clock. So adding extra details before coming to the actual point is called as circumstantiality. I hope it's clear. Then coming to tangentiality. So here when we ask where is your nose, the person keeps rotating here, somewhere, not coming to the point at all. He just goes somewhere outside from the actual point. That is called as tangentiality. Then coming to neologism, coining of new words is called as neologism. Then word salad. Like when you remember, like what is salad means, like mixing of different words. That is called as word salad. Then ambivalence. So having hatred and love, having two feelings towards something, we call it as ambivalence. When we say say yes or no, they don't want to say either yes or no, somewhere between, agree or disagree, no, neutral. This is like ambivalence. Then perseveration, same things again and again, the same thought which repeats again and again, that is perseveration. Next, coming to thought content. Under content, we assess for delusions. What is delusion? Delusion is defined as false, unshakable belief. It is defined as false, unshakable belief. Unshakable belief means a belief where a person holds, and this belief, in spite of several explanations we try to attempt, the person is not still convinced. That is said as false, unshakable belief. Now, for example, I will tell, like delusion. We have so many types of delusions, in our life as well. Like if a black cat comes in front of us when we are going in search of some job or something like that, we say, okay, something bad is going to happen. It is a delusion, isn't it? So, like some say, no, it's not a delusion. Okay, well, you believe in that. You don't want to get convinced. We say Amavasya, something bad is going to happen. Well, we cannot convince people because they believe in that. So, scientific point of view, we find no reason for that. But still people keep believing because they think that is true. So, delusions are like that. False, unshakable beliefs. A person believes that somebody is trying to harm him or torture him. That we call it as persecutory delusions. Especially in paranoid schizophrenia, they suffer with paranoia, suspiciousness that others are trying to conspire on him, others are very jealous of him, or others are trying to do some harm for him. So as a result, there is loss of trust. They don't trust anybody. They don't eat anything what others bring. So these are like persecuted type of delusion. We have delusions of reference. Now delusions of reference, we say, we can say that if other two people are talking, maybe they're talking related to me only. They're talking about me. This does happen in our normal lives, isn't it? Suppose you just had a fight with your friend and she just left you and you're not talking with her for few days, and the other day you find your friend talking to another classmate of yours, and they both are talking and laughing something. You, when you're passing that way and you say that they are talking about me and they're laughing, that is like delusions of reference. They feel that others are what others are talking is regarding to that person. Next, delusions of influence. They feel a person is trying to influence, and that's the reason they are behaving like this. Where we see delusions of influence in witchcrafts and all, we try to say like when somebody is ill, somebody did something, they're trying to influence this person, that's why she's behaving odd. Next, we have hypochondriacal delusions. This is like too much concern, exaggerated concern about their individual body, and they have a feeling that they are having some serious illness harboring in their body. That is the belief what they have. Delusions of grandeur, grandiosity, thinking high about themselves. They think that they are crororepatis, or they have they know famous stars, or they have possess a lot of like cars or money, building, or Superman, Spider-Man, extra powers, etc., etc. Delusions of grandiosity, telling great about themselves, boasting about themselves, of possessing some superpowers or some positions, finance, etc. This we call it as delusions of grandeur. Next, nihilistic delusion. When we say nihilistic delusion, these delusions are often seen in patients who are suffering with severe depression. They feel that they are not alive. They feel that they are already dead and that somebody else is living in their body. They're dead long back. Like a person, when they're really depressed, they just imagine, they tend to get thoughts like, I wish I could die, I wish I could die, and they feel, they go to an extent that they're already dead. That's how it is. Like when we are really depressed and someone has broken our heart, and later when they come and ask, how are you? You say, where am I? I'm already dead. Listening to your words, that's what we use, isn't it? So when we say nihilistic delusion, a person feels that they're not alive. Next one, delusions of infidelity. So here, infidelity, they believe that the other person is trying to fiddle with the person, seduce the person sexually, or trying to mold the person. That they believe like that. Others are infiddling with them. Delusions of being in control, that someone else, some power is controlling and telling them to do certain things. That's the reason they're doing all this. Bizarre delusions, when they do not have any clarity, we call it as bizarre delusions. I hope I'm not too quick on this. So these are different aspects we assess under thought. So how do we assess actually thought? How do we get these contents? What type of questions do we need to ask the patients? You have to ask, so what are you thinking about? Are you thinking on something? And you go in detail regarding that. So depression patients, you will be asking some questions. How are you feeling now? Are you sad? Why are you sad? Do you have any suicidal ideations or suicidal thoughts? If so, were you hurt in your life? Or do you have any other plans, etc.? All those things. or if they are having any sorts of delusions, we have to dig in detail on each and every aspects according to what answer they are giving to us. And while they are talking, we have to assess the stream, form, and delusions. And apart from that, still we have other things as well. Ideas. If they are having any ideas of worthlessness, helplessness, hopelessness, guilt, death wishes, all these we can assess in depression patients. Now, coming to delusions, mostly we see in maniac, schizophrenia patients, delusions we can see. Some maniac patients we can see delusions of grandiosity, and psychotic conditions we can see the circumstantiality, tangentiality, or new words, etc., etc. In depression we find all this worthlessness, helplessness, hopelessness, suicidal ideation, and all those. Next, coming to thought alienation phenomena. Here, thought insertion. So here the person feels that somebody else is trying to put thoughts in them, and it is not their thought, their own thought. That is thought with insertion. Then some might say, my thoughts are being removed from my mind. Somebody is trying to copy. Actually, I am thinking that, and that other person is trying to say the same thing. They are removing my thoughts. Then thought broadcasting. They say like whatever they are thinking is shown on TV, and they can hear from others. That's how they say, like thought broadcasting. Then we can also observe for obsessional phenomena like thoughts or imaginations. Ruminations are nothing but keep repeating the same thought again and again. We say it as or same on same topic or same content again and again. We say rumination. Doubts, impulsive rituals. This we can see in OCD conditions, obsessions, compulsions. You can go back to OCD and just see. Then phobias. This also we have discussed. Phobia means irrational fear. Then apart from that, if they are having any preoccupations also we can observe or assess in thought. Then next, another component of mental status examination is perception. So what is the definition of perception? We know sensation. Sensations are nothing but sensory impressions or stimuli which we receive by our sense organs. We call it as sensations. When we use this word perception, that means when the sensory inputs are organized and interpreted in a meaningful manner, we call it as perception. So whatever we receive through our sensory organs, those are like sensory inputs, stimuli, and we organize them and we interpret. Suppose if we try to hear a sound from far away, and that is like through our auditory, we try to hear that sound, then we say it's a sound of from train is coming. And how far is the train? It's quite far, we say, depending upon the sound we hear, because we organize. So under perception we have illusions. So misinterpretation of a external stimuli, in presence of an external stimuli, we call it as illusion. That means there is a presence of stimulus is present here. For example, you see a long rope and you perceive it as what? Snake. You perceive it as a snake. That we call it as what? Illusion. There is a presence of a stimuli and you misinterpret, that is called as illusion. But coming to hallucinations, there is no stimulus. That you have to remember. There is no external stimuli which is present. But in absence of stimuli, still person sees, olfactory, visual hallucination. Person hears, auditory hallucinations. Person smells, Olfactory hallucinations. Person has different taste, that is gustatory hallucination. Person feels that something is crawling on their skin behind or wherever it's crawling on their body. We call tactile hallucinations. Then somatic passivity, body. So you, and next one is deja vu and jamaisu. Deja vu is mainly a strange feeling. We can say that when we look at someone, we say like, "Have I seen you before somewhere?" A strange feeling of familiarity, that we have seen that person before, seen that environment before. That is called as deja vu. This happens, isn't it? Sometimes when we go to some places, strange places where we haven't gone before, and there someone sees us and comes to us and say, "Did I see you somewhere? You seem very familiar to me." You might say, "No, I haven't seen you any time." So this type of familiarity, we call it as deja vu. Jamaisu is opposite of it. Being in a known place and telling, "This place seems very strange for me." Jamaisu. That's the meaning of it. Then we have depersonalization and derealization. Depersonalization, where the person really feels that he is, "Am I the real person, and is this really happening to me?" Derealization, where a familiar environment seems very strange for us. This happens in PTSD's, post traumatic stress disorders, where there is a shock for our mind. Suppose, for example, any terrorist attacks, bomb blasts, or any disasters during those times, like floods, earthquakes, where it happens all of a sudden and we feel very strange with ourselves as the environment. That is like depersonalization and derealization. Next, we are moving on to the other aspect, cognitive functions. So this under neuropsychiatry, this comes under neuropsychiatric assessment, as well as under mental status examination. We also do this cognitive assessment. We assess for consciousness, cloudy, comatose, orientation to time, place, person. So we ask person, "What time is it? Where are you? Who is with you?" We can assess orientation in this way. Next, attention. Normally aroused with difficulty. How we can assess attention and concentration of a person? We can say whether it is sustained or sustained with difficulty, distractible. So you can ask using various ways, like asking the person to mention names of the week and to just repeat them from backwards. You have to literally ask them to say it out, because then only you can assess whether they have this concentration of telling them backwards, like Sunday, Saturday, Friday, Thursday, Wednesday, Tuesday, Monday, etc., like that. Months of the year, and asking them to say backwards. You can ask them, like if they're educated according to their level of education, you can ask these subtractions, like 100 minus 7, and ask them to keep repeating backwards, like 93. And then 93 minus 7, it says 76, then 86, then 79, etc. Ask, if they are not that very educated, you can ask them to subtract 40 minus 3, or 20 minus 1, 19, 18, 17, like that. According to their level of education, we need to ask these questions. Next, coming to other aspects like memory. Immediate, recent, and remote. The best way to tell is like you can just tell names of 3 objects in front of you, like pen, paper, pencil. Just remember, ask them to repeat and ask them to remember. At the end of conversation, you can ask them to repeat the 3 things what you told, like pen, paper, pencil. If they repeat, then their immediate memory is good. Then recent happenings. Yesterday, what did you eat? Did you have any yesterday visitors yesterday? It comes like 24 hours to 48 hours span. Recent happenings, you can ask questions on that and assess. So verbal recall, then we have unrelated objects, 5 unrelated or imaginary address items, etc. Then coming to remote memory, we can ask like personal events, date of birth, class where studied, parents' date of birth or marriage date or children's date of birth or something related to their personal events can be assessed. This is how we can assess immediate, recent and remote, and we can write whether memory is intact or recent memory is intact and remote not intact. Then coming to other aspect we can which we may assess is intelligence. Under intelligence, we can gather general fund of information which is mainly related to who is your ward councillor or who is the chief minister or prime minister, etc. Then arithmetic ability, based upon their education level, we can ask simple calculations like additions, subtractions, multiplications, divisions. If we add 7 plus 3, how much it is? If you subtract 3 from 7, how much it is? Or if you buy 3 pens and each pen costs 5 rupees, how much 3 pens cost? Divisions, 3 pens cost 15 rupees, how much each pen costs? All such type of questions we can ask. The next one is abstract thinking. Under abstract thinking, we have similarities, dissimilarities. So you can ask similarities, pairing two objects like a stone and potato which are same, or two-wheeler or a lorry, similarities, and dissimilarities between two objects. Then we can ask them regarding interpretation of proverbs like we can say every dark cloud has silver lining. So what is the actual meaning of it? Birds of the same feathers flock together. So there is a different meaning for it, isn't it? So we have other things like rolling stones gather no mass. Abstract thinking can be assessed in this way, and whether it is present or not, you can write on under interpretation. Next, we have judgment. Under judgment, we assess three areas like personal, social, and test. When we say personal, we can ask the patient like, "What are your plans for your life?" If they say, "I don't have any plans. I just want to sit and eat," then what do you say? Like, so they don't have any plan as such. If a person says, no, I have a lot of responsibilities, I have to get back to work, I have to do this, I have to perform this. So you can assess their future plans. That is how you can judge personal aspect. Then coming to social aspect, perception about the society, how they perceive the society, social responsibility, whether it is there or not. Suppose you can ask a person, you go on the road and you see an old man just trying to cross the road and finding it difficult. What do you do? Then I am not bothered about that person. But this person doesn't have social responsibility. Nobody did good for me. Why I should do something for them? That's how it is. Like some might respond, oh, well, I'll take some time and make the person cross the road. That's how it is. That's how actually a person is supposed to respond, isn't it? Then regarding the test, present a situation, then ask for the response. Suppose if we say like in front of your house there is a thatched house and which caught on fire, then what you're going to do? Oh, come on, I am going to throw stones at that house because that person is not very nice with me. If you get such type of response, then is it right? No. So genuinely, what should be the response? We should take some initiative to put some water on that house, or try to make a call to the fire station and intimate them and call for help or something like that. You have to present some situation. Maybe an envelope, if you receive an envelope with a wrong address, what do you do? I don't do anything because it is not right for me. I'll tear it off. Then that's not right, isn't it? What is the actual response that should be? You have to redirect it, isn't it? So you have to assess how the person is responding. According to that, we can tell the person is having adequate judgment or not. Then coming to the last aspect of it, mental status examination, insight. Insight, what is meant by insight? Having an awareness of what a person is having, what condition a person is having, what the person is going through, that is said as insight. Knowing where they are, what they are suffering with, and why they are suffering with, that is insight. So sometimes when we ask these patients who are admitted in hospital, do you know what is happening to you? Then they say, nothing is wrong with me. Simply they brought me to hospital, but everything is fine with me. That means insight is absent. So we grade this insight on a point scale from 1 to 6, and it is here. If they say nothing is wrong with me, complete denial of illness, then we say grade 1 insight. Then slight awareness of being sick. They know they are not feeling well, but they really don't know whether they are having physical illness or mental illness. I'm not feeling well. I really don't know what is wrong with me, but something which I don't know. That is grade 2 insight. Then 3 is awareness of being sick attributed to external or physical factor. My body, I'm having illness with my body. That's what they say. Next, 4, awareness of being sick but due to something unknown to himself. They say, I am sick, but I really don't know what is wrong with me. Intellectual insight. So here also they say that they are sick, like with something mentally, but they really don't know what it is they're suffering with mentally. That is, they have slight awareness. There is something wrong with their mind. Intellectual insight. Then true emotional insight. They say, I'm having depression, I'm having depressive thoughts, that's what I'm suffering with. I have anxiety, so I have phobias. They know I'm having some problem, that particular problem, they know what they're suffering with. That we call it as true emotional insight. So these are different components of mental status examination. And to summarize it, we have seen general appearance, behavior, then we have gone through different aspects like speech. We have gone through speech, and apart from speech, we have seen about thought, and we have seen about perception, we have seen mood and effect, what it is. Then cognitive functions. Under cognitive functions, we have seen about consciousness, their orientation, memory, immediate, recent, the attention and concentration, then judgment, then abstract thinking, whether it is present. Then apart from that, we have seen about insight. I hope this is a very useful session for you. Before I could conclude, thank you all very much. Please do subscribe this channel and share to others, and we'll be back with another topic. I hope to see you all back soon. Thank you all very much once again. Bye bye for now.